Hello, everyone. Today we have another lecture of Principles of Surgery focused on skin cancer. And today's guest speaker is Dr. Boland, an associate professor of surgery at Harvard Medical School, section head of melanoma sarcoma surgery, and surgical director of the Termeyera Center for Targeted Therapies at the Mass General Hospital. Dr. Boland's primary clinical focus is on melanoma and cutaneous oncology. Thank you very much, Dr. Boland. We are so happy to have you today and looking forward to hearing your presentation.
Okay, great. Well, thank you for the invitation. I'm going to just share my screen here for a second. All right. Does that look okay?
Yes.
Perfect. Great. So I'm going to talk a little bit. The ask was to talk about melanoma and other skin cancers, but I'm sort of cheating and I'm going to talk a lot about melanoma because that's what I do a lot of. And there are a whole bunch of other skin cancers. I'll touch on them briefly at the end. I also have a plug at the end, but I'm part of the SSO, the Society of Surgical Oncology. I'm the chair of the disease site working group for melanoma and skin cancers, and we have a lot of resources. So if I don't cover things you're interested in, but you want to know more, I'll include my email and some resources that can connect you to some information. These are some of my disclosures. I work a lot with industry because we're trying to figure out from biology to new therapy. I don't run any of the trials. So I'm going to talk about melanoma. It's a rare form of skin cancer, but it accounts for a lot of the mortality from melanoma. So although it's not the majority, and you know, I'll talk a little bit about squamous cell. I didn't even touch on basal cell. And cutaneous melanoma can occur anywhere on the skin, and not as common as other skin cancers, but again, responsible for the vast majority of the mortality. And it's a global problem. It's been very interesting. We've set up multi-institutional and multinational collaborations with people from all over the world, looking at both the incidence, but also the biology of melanomas as they occur in different places. You know, they may be the same disease, they may be different diseases, but I think that building these international collaborations are incredibly important to make sure that the findings that are coming from our clinical studies or our research studies are representative of the patients who are being treated. And, you know, for the trainees in the room, I remember when I was a trainee, I hated staging. You had to memorize it for each disease, and it seemed very dry. But, you know, as a cancer surgeon, really the staging is important to stratify risk. And that risk stratification is how we make clinical decisions and how we counsel patients. So something that I thought was very dry and sort of something you had to memorize really matters when it comes to how we counsel the patients and help them make decisions regarding surgery or other treatments. A quick and dirty way of thinking about this for most, not all cancers are stage 1 and 2 are local cancers to varying degrees of invasiveness or risk. And then stage 3 is nodal disease. Stage 4 is widespread metastatic disease in solid tumors for the most part. This is not always the case. And then there's clinical staging and then pathologic staging. And I would say most of us really rely on not just your clinical examination, but the pathologic findings, either from the biopsy of the skin cancer or eventually from nodal staging by sentinel lymph node biopsy. And again, these are dry topics that as a trainee, I thought were really boring. All I want you to see is the change in the color, right? If we think about stratifying risk, if you have a really low risk group and a really high risk group, but they're bundled into the same basket, you won't be able to give a person, the individual in your clinic, a really good idea of whether they are at risk or not. So over time, the staging system has tried to evolve or emerge to do much more refined stage matching. So pulling out the high risk into a separate groups and really bundling the low risk. So then we really understand who's going to do well, or at least can try to infer that information. And I think something that's unique to melanoma in particular that's not seen in other cancers is that the primary tumor biology really tells you a lot about what's going to happen. And in melanoma, because the primary tumors are tiny, they're often removed in the biopsy and we don't always see them, we haven't been able to study that biology as deeply. But what this is showing, these are Kaplan-Meier curves or melanoma survival curves for stage 3. So those are patients with nodal disease. And you can see the stage 3A do really, really well. In fact, many times after surgery, we don't do much more. Stage 3B kind of here, stage 3C worse, stage 3D really terrible. We get nervous. But this little gray line here is stage 2C. Those are patients that do not have nodal metastases, but have a high risk primary, and they do as badly as stage 3B and worse than 3A. So it's not just whether the tumor has left where it started and metastasized, it's actually features of the primary tumor that can really give us information about risk and whether the patient's at risk of recurring. I'll also put in a plug for those of you, if you find yourself not knowing what to do, and these guidelines exist for every cancer type or most cancer types. And I'm on the NCCN, so we create or curate the guidelines used to help guide care, standard of care. Obviously, each surgeon or each medical oncologist can deviate from that, but this gives us a common place to start. And when you're in new diseases or in new settings and you want to know what to do, these are good resources to use. So, this is the part that our trainees see a lot, which is the surgical management of skin cancers via wide local excision. It's not super complicated, but it's curative cancer surgery, right? You can do a relatively minor procedure and prevent subsequent metastasis and death from cancer. So even though the technical aspects of the surgery are not as immense, the intervention is huge. And this is, again, for people who are really invested in the field. You don't have to learn this, just showing that the margins, the width of excision that we use are actually based for the most part on data. There's some places, because in the past, before even I was training in surgery, people would do massive excisions that were probably unnecessary. And I think over time, a theme you'll see a lot of across different cancers is how much surgery is enough without doing too much, right? We don't want to do morbid surgeries if they're not necessary. And so there is an ongoing trial that's accruing to see if, historically it was 1 centimeter margin for low risk melanoma, 2 centimeter margin for thicker melanomas. And that was based on the trials I just showed you, but this trial is ongoing to see if we can do a slightly more narrow margin. Again, in real life, it doesn't matter too much unless you're talking about the hand, the face, the foot. But it's important to do that. So moving on, when I counsel patients, I say, I can cure your cancer with a wide local excision, but the question remains is, did any cells leak out? And 80% of the time, the first place they're going to go is to the lymph nodes nearby. And this procedure called sentinel lymph node biopsy is a nice, elegant way of injecting dye. You can see here right at the melanoma, and it follows the pathway a melanoma cell would follow. So it's not specific to melanoma. So I tell my patients, they get very confused. Just because the dye goes somewhere doesn't mean you have cancer. The dye is a marker for where the cells would go, and then I can use it to remove the cells. So this is not a curative surgery. This is information gathering. And this was the study that showed us that. So MSLT1 was a prospective randomized trial studying standard of care, which was wide excision versus using the sentinel node. And you can see here just by looking that adding the sentinel node didn't add any improvements in outcomes. But what you can also see is it very specifically correlated with risk. So it's a prognostic feature that's really important in how we counsel our patients. But interestingly, what we noted is that, oh, sorry, was that a question? Okay, sorry. We noted that at the time, the standard of care, if you had a positive sentinel node, what I would tell my patients is, this is the canary in the coal mine. Maybe that's a phrase you don't use, but this is a marker that perhaps there's additional disease, right? I did a checking sampling, but perhaps there's more disease, and let's go in and do a curative surgery. So what we would do is we'd sample the lymph nodes, but then we'd go back into a completion lymph node dissection. That was curative intent, right? We would say, we sampled one node, we found cancer, there might be more, let's go and remove it all. But 20% of the time we found more disease, and 80% of the time there was nothing more there, suggesting that perhaps we were over-treating those patients. And so this was a prospective randomized trial comparing, complete node dissection, which was a standard of care at the time, with nodal observation. So this is only patients that had a positive node, and they would either receive upfront complete lymph node dissection, which is what we were doing, or we would observe them with nodal ultrasounds every 4 months for the next few years, and then only operate on patients who progressed in the basin. And you can see here that there was no difference in melanoma-specific survival. So what that means is that by monitoring patients and operating only on the subset of patients who actually had more disease, that 20%, it didn't decrease their overall survival, and it didn't result in them having tumors that pop up somewhere else, which is always a concern. And certainly it did decrease the morbidity. So then in melanoma, there's also this really interesting pattern. So non-nodal regional disease. You don't see this in all cancer types, so that's a sort of an interesting pattern that we see. And that's where patients can occur anywhere between the primary tumor and the nodal basin. And some of these patients, you can see, this is one of my patients where he had his wide excision, and then you can see these little sites. And they used to just differentiate microsatellite, satellite metastasis. But right now we just call anything that's not the primary, that's nearby, but not in a regional nodal basin. And it's sort of interesting biologically, because lots of these patients can have terrible burden of disease. In fact, this patient progressed all over the place. It was horrible, but didn't metastasize to the lungs or to the brain or to other places. So biologically, it's probably a little different. What we like to do is, obviously confirm the diagnosis. And then the question becomes, what's the right local therapy? You have a local problem, but one that might continue to progress. So, in somebody like this, surgery is probably not the right answer, because the minute you pop, you cut out one of these, and another few are going to pop up. But there are now injectable therapies. Historically, we used to use regional therapies. You'd isolate the limb, cannulize the vessels, and actually give chemo just to the leg. We don't do that so much anymore because we have better systemic therapies that kind of do the job. And, I think one thing in cancer that's pretty common, but I think very particularly in diseases where the therapy are changing over time, that a multidisciplinary approach is important. So, when I give talks to general surgeons in practice, if they have the ability to, and you may not have that luxury, it's better to be seen early on by a team of people who can kind of integrate all the different modalities we have to treat and make a bigger picture decision. And, we have new therapies that have really changed the calculus. And so as a surgeon, it's funny that I'm talking about drugs, but that's an important part of what's changed our practice. And I like this slide because, targeted therapy, I grew up where we treated things with chemo, and in some diseases, we still do that chemotherapy. And it's very effective, but it just kills cells that are growing, and it kills cancer cells, but it also kills hair cells and gut cells. Molecularly targeted therapies are drugs that only treat mutations that occur only in the cancer. It's very elegant, right? Your cancer evolves to have a mutation, and we find drugs that only treat that mutation or cells with that mutation, which is great because in the right patients, you can see that it pushes the progression-free survival, but you can also see that in patients with advanced disease, they're going to eventually recur and often die of their disease. Immunotherapy, which is a category of drugs I'll talk about a little bit, is a drug that doesn't actually kill cancer directly. It's kind of interesting when you tell a patient, I'm going to give you a drug that doesn't kill cancer. The drug just helps your body's own immune system to see the cancer and fight it off. So this part is less predictable about how they're going to respond and when, but in a subset of patients, they have long-term durable control. The idea of turning cancer into a chronic disease. I don't like to say cure because I'm a little reluctant to do that, but really getting ahead of it, like we would vaccinate to prevent infectious disease. The idea is, can we treat the immune system to kind of maintain memory to keep cancer from coming back? And the biology of this is here, which is, cancer is you, but not you. And, it comes from you, but it acquires mutations that your body can recognize as foreign. And so ideally, in the perfect world, your immune system can recognize that the cancer is not you or foreign and can be activated and gobble up and kill the tumor. That's the perfect world. But I put here this yin and yang. People like to think about a patient responded to a treatment or did well from a treatment, but they like to put them into these very clean baskets. You got benefit, you didn't. But it's actually not the case. The immune system and the cancer are constantly fighting one another. And I think we need to think about balance. How do you improve the function of the immune system, and how do you undermine the function of the tumor to get the best outcomes for patients? Because there's a lot of ways the immune system can evade, or rather the tumor can evade the immune system. And again, I know this is a surgical audience, but I think you have to integrate what's going on more broadly into how we're treating patients. And I call this the eye test. You don't need to be a trained, clinician or expert to know that the left is bad and the right is pretty good, right? So these were, when I started in medicine, the left curve was your prognosis if you had advanced melanoma. And, with the advent of these newer therapies, you can see that the, survivals are better. You can start to see that little bit of that tail on the curve. So patients are doing better and living longer, which actually impacts the surgical management of their disease. Patients that might not have been ever considered for surgery might be reasonable candidates. And so this is just from one of the big trials in systemic therapy. You can see this tail on the curve. And I'd say we in melanoma are seen as one of the successes in cancer. We have good treatments that are potentially life-saving. But if you treat for these patients, for those of us who do this every day, many of them will develop resistance and go on to succumb of their disease. So we're not done improving what we do. There's still a lot of motivation to do it better. And interestingly, most cancers, if you look at the epidemiology data, there's more cancers detected every year. The mortality is incrementally going up. And melanoma was one of those cancers too for a long time. But in the modern era, this is since some of these therapies have been used, the numbers of death overall from melanoma in whites, and that's the largest proportion of cutaneous melanoma, have fallen by about 18% overall, so 6% per year, the largest drop in any cancer ever. So it suggests that the therapies we're using are actually life-saving. And this was a study we did from the National Cancer Database here in the US. We were just looking at utilization. So now that we have good treatment, are people getting them? And is that impacting surgical use? And really, we didn't find a lot of differences there, but we did find that getting immunotherapy, even within the US, really was not equal or equitable. And there were a lot of disparities in access to care. So this for us is, a wake-up call that we need to do a little better. And then I'm moving on. And again, you'll say, what is this relating to the surgical management of skin cancer? But all of these pieces are involved. And I think as surgeons seeing a lot of different complications, these things are important, because as we begin to turn people's own immune system on to fight cancer, the toxicities or the bad side of that is, like I said, cancer's you, but not you. So autoimmune toxicities, your immune system's all activated and excited to kill the cancer, but it's existing in a background of normal tissue. And so your body can get confused and you can have myocarditis, which is potentially fatal, endocrinopathies, which are not reversible. So you can get type 1 diabetes, which is a real bummer. And so, as we've started using these drugs, we've begun to learn that these toxicities are real. And in your practices, you may see colitis, for example. And immune-related colitis in the setting of immunotherapy is not a surgical problem. It's not like C. diff colitis. So, educating surgeons on what are these things you're seeing in the context of some of these new therapies and how you manage them is actually a little bit different. Non-intuitively for these autoimmune toxicities, you want to give steroids, right? Which is not what we would do for other types of colitis. And when you counsel the patients, it's a real bummer to have an autoimmune toxicity, but the good news is it actually correlates, or some of them correlate with better outcomes. So what I tell my patients is, I'm sorry that you're having this problem. Really is not pleasant at all, but maybe it's a good sign that your immune system's doing something, right? It's activated, it's doing its thing, and there's clearly a correlation with outcomes. We began to worry that maybe when we started to treat those toxicities, like I said, when they're really bad, we treat them with high-dose steroids to turn back the immune system. But it's like we're turning it on, we're turning it off. And we found through this study, and this was a multinational, multi-institutional study with groups all over the world, that if we over-treated with steroids too early, we actually undermine the efficacy of these treatments altogether. So for us, we want to maximize benefit and minimize harm. And so some of these little nuances are important. So what else has changed? Well, in the surgical world, initially we started using all these therapies in stage 4 melanoma. These were patients who had no other options, and it was hopefully, curative or potentially at least helpful therapies. But as we began to get familiar with them, the question became, well, maybe we can move them earlier in the care trajectory. So in patients who are cured by surgery, in theory, but have a 30 to 50% chance of recurrence and or death in the next 5 years, perhaps we can use these for risk reduction. And these are just a list of some of the trials that have been used in the adjuvant space for melanoma. But the important thing to note is that when you're using things for risk reduction, that risk-benefit ratio matters, meaning if you're going to die of your disease, you'll accept any toxicity as acceptable so you don't die. But if you're potentially cured, but you have a risk of the disease coming back, that balance of benefit to risk, and as I said, some of these side effects are not reversible, becomes a much bigger deal. And then as we started using them in stage 3, which is patients with nodal disease after surgery, it became a question. I showed you that these high-risk stage 2 patients are actually at pretty high risk, and should we potentially be using them after definitive surgery in these patients? And this was, Jason Luke presented this. This was looking at pembrolizumab or anti-PD-1 after surgery in patients who didn't even have nodal disease, which did show some benefit and eventually was FDA approved here. But again, when this was approved, we all thought it's great. All our patients are going to start getting this therapy, but a lot of them aren't because of this idea of toxicity, right? They have a risk of recurrence, but it's not a for sure thing. And so, the adoption in real life practice has been a little slower, I think, than anticipated. And it varies. If you go to Pittsburgh, where these folks are, you'll probably get it because they're going to downplay the risks and play up the benefits. And at our institution, we're a little bit more cautious or moderate. So I think there's no right answer, but it just shows you that, what we have as options are improving, but we don't really know what to do. And another thing, this is just sort of as a side note, but I think as a scientist, as well as a surgeon, I thought it was really interesting, is in patients being treated with these immunotherapies, you can have the same patient at the same time that has tumors that are growing and shrinking, depending upon the site. It's not pseudo progression. It's truly one tumor is responding and one is not. Super weird. And that's that yin and yang, that push and pull. These are patients that I think are somewhere teetering between not responding and responding, and their body's saying, I'm kind of getting there, but I haven't quite gotten there. And they do somewhere in the middle. And this in-between state can last for years, actually, for months to years. And eventually patients will tip into good or bad. And we looked at the prognostic features of that, which I think, unsurprisingly, lower burden disease without brain mets, patients do better. But I think biologically and clinically, that's an interesting question. And this was a study we did, again, a multi-institutional, multinational study, looking at the kinetics. I told you that when you treat with these drugs, it's not like, okay, 5 days later, the tumors are going to shrink. You never really know. But we also didn't know the difference between initial resistance, so a patient who never gets benefit, from secondary resistance, meaning you get some benefit, but eventually you recur. But if you look at these secondary resistance patients, most of them have a new lesion or just 1 or 2 sites of surgery. So what that says to me is those are probably surgical patients, right? These are patients that have gotten benefit. Their body kind of did what it could mostly, and there are 1 or 2 places that are either new or persistent that haven't quite been treated fully. And those are patients, even in stage 4 metastatic melanoma, that probably would benefit from surgery. And so we again looked at our NCDB data set to say, well, what are the trends? And we saw that the trends were pretty stable over time, but that there, was a group of patients. So if you didn't get immunotherapy or surgery, you did poorly. If you got immunotherapy, no surgery, or if you got no immunotherapy, were a candidate for surgery, you did kind of well. But there's a subset of patients, if they're able to get immunotherapy and get surgery, that seem to do even better. And again, we don't have the granularity of data here to say, are those that same patients that I saw in our previous study? But in looking at our practice patterns, I would guess that those are the patients. They're getting a benefit, but not quite 100%. And can you consolidate their response into something much more durable by removing the 1 or 2 sites of disease that just aren't getting there? And that's been kind of our approach. And then as we move from stage 4 to adjuvant, the question becomes neoadjuvant. But for all of you who are used to neoadjuvant in, for example, rectal cancer, when I was first familiar with neoadjuvant, the purpose of neoadjuvant was a couple things, but one was to improve the morbidity of the surgery, right? In rectal cancer, perhaps you can turn somebody from an APR into an LAR, or improve the resectability of the tumor by giving neoadjuvant, right? It makes it a less morbid, easier, and same with breast conservation. But in melanoma, resectability wasn't often the problem. And so we could do targeted therapy to shrink the tumors, and that helped. It also gives you the opportunity to assess response in vivo, meaning you can assess if that given patient is going to respond to that given treatment by looking at their surgical pathologic response. And then in immunotherapy, it's like, why would you give a drug that doesn't necessarily shrink the tumors before surgery? I mean, it doesn't really make sense, except it does, because if you think about what immunotherapy does, it's trying to train your body's immune system to kill the tumor. And it may be better to broaden that training. So, right, to inoculate against the full tumor as opposed to the little bits and pieces that are left behind after surgery. But there was no clear winner. And there's been interested in neoadjuvant studies of drugs, of intralesional things with drugs, of targeted therapy. And there was a lot of interest in combinations of immunotherapy. People were concerned that one drug by itself wasn't enough, that patients would progress before they ever got to surgery, and then you would have missed your window. And that was a lot of the pushback from some of these trials. But what was clear from the trials too is that in patients who had a pathologic response or a near pathologic response, they were going to do pretty well, right? So treating a couple cycles, doing their surgery, and then looking at the pathologic response really gave you a window into whether they were going to do well or not. And people have been interested in using that data to start making decisions about, do you need more surgery? Do you need more systemic therapy? And this was a group in Europe who actually put a little fiducial or a marker in the index node, or the node that was biopsy proven. And they looked and see if the pathologic response in the index node was similar to in all the nodes. Because the question was, could you just remove the pathologic node? And if you had a full response, spare the patient a bigger surgery. And that's what they did in this Prado study, which in reality has been criticized significantly because they didn't do it systematically, and they made some bad decisions about de-escalating too quickly. But I don't put it up here to say this is what you should do, but rather this idea that eventually we'll get to a point where we can treat before surgery for bulky stage 3 or 4 disease, and then look at the pathologic response and decide, are there people that can get nothing more? Are there people that need more surgery but nothing else? Are there people that need more surgery and more treatments? And in our lab, in my lab, one of the questions we want to answer is, can we figure out what they need? Meaning, can we not just look at pathologic response, but can we use tools we have in the lab to say, what is the mechanism by which they're not responding, and figure out the better combinations? Because right now we're just picking things off the shelf as best we can. So that's sort of this idea of personalized medicine, which is coming. But this was a study that came out just this year, 2023, that really changed our practice. And they did something really simple that nobody really thought was going to work. We had adjuvant immunotherapy, PD-1 monotherapy. So you got surgery and then you got 1 year of drug. And they took that 1 year and they gave a couple of 3 of the doses before surgery. So nothing else was different. Same treatment. You were going to get surgery plus adjuvant. And instead they moved 3 doses before surgery. And they found that the patients did significantly better, much more so than could be explained by many other things, except this idea that perhaps getting the immune system to see the full tumor before surgery actually is beneficial for suppressing its recurrence or keeping the immune system active against it afterwards. And you can see it made a big impact, New England Journal of Medicine, but it really changed our practice overnight, right? There was no data to support doing this. And now this is what we do. This is standard of care for stage 3 disease. And then, again, I know this is a surgical audience, so you don't necessarily care, but there's been a lot of interest in stage 4, but I think which bleeds into stage 3 and earlier diseases of like, what's the best drug? What order should we give them? How do we balance the toxicities of these drugs with other things? And so take home is combinations are better, but they're more toxic. And there's a lot of work going on with new combinations that have been approved. And again, all these things in stage 4, like when I speak to our surgical trainees, they're a little less interested in some of the systemic therapy, but I'm like, these are things that are coming in the neoadjuvant setting. So even though it's not in your domain yet, these are combinations and drugs that will then be used pre and post your surgery. And so understanding how they work and how they integrate with that will be pretty important. And then this was a study that looked at order, right? We have targeted therapy, we have immunotherapy. Nobody knew what order. And there was a clear winner that immunotherapy should come first. And that's your best shot, at least in the setting of stage 4 disease. So what else is coming back? I think, I'm supposed to talk about skin cancers. And I would say that a lot of these lessons from melanoma actually apply to a lot of these other, particularly cutaneous squamous cell carcinoma, and then Merkel cell carcinoma. Those are tumors that are, the cutaneous squames are often either virally or UV driven. And so they are similar to melanoma, quite responsive to these immune therapies. But now that we have this sort of backbone of these immune therapies, we're revisiting other things like vaccines. Many of us got COVID RNA vaccines. Well, we were working with Moderna before that, and the data that's coming out from RNA personalized vaccines looks really good, right? So can we, before surgery or at the time of surgery, send the tumor to make a vaccine? And then in the adjuvant setting, we give them the personalized vaccine plus immunotherapy. That data looks really, really good. Similarly, we're working on adoptive T-cell therapy, and it's sort of a crazy thing that's going to be FDA approved this year. But what we do is we do surgery to remove a tumor, not for curative intent, not for any therapeutic benefit, but to obtain immune cells that we then send to a company. They take the person's own immune cells, they expand them, they activate them, and they give them back as a living drug. It's more like transplant than other things. But it's really, really exciting, and historically was only able to be done in specialty centers. And then there's CAR T cells and other things that are kind of, down the line. To focus for a minute on some of the other skin cancers, cutaneous squamous cell carcinoma is a big burden of disease. I don't have time for a comprehensive overview. This is just a little flow chart. The low risk squamous cell carcinomas are just a clinic problem, right? These are things that just need to be fully removed so that they don't come back, or removed to negative margins with a narrow margin excision. But in the high risk patients, they are at risk of, spread to the regional lymph nodes, which can be managed surgically or with radiation. and should escalate in terms of monitoring, and for whom in the metastatic setting, there are some good systemic therapy options. And I would say the lessons in a lot of these diseases are similar to melanoma, meaning we're using more of these immune-based therapies for these patients if they have highly locally advanced disease or recurrent disease. And another rare skin cancer called Merkel cell carcinoma is a disease really of the elderly. You can see here that it occurs, and it's rare, super rare, but it can be pretty aggressive. It doesn't result in all the mortality that melanoma does because the burden of disease is low. It's pretty uncommon, and it's either formed by UV exposure or by virus, similar to cutaneous squamous, although a different virus. But it too is pretty responsive to some of these same therapies. So I would say, not all skin cancers are created the same, but for some of the more aggressive ones, this sort of framework of thought and the way we treat them is kind of emerging to be relatively similar, obviously with some differences. And then, as I mentioned before, the SSO, the Society of Surgical Oncology, is a wonderful organization for any of you who are interested in cancer. We're very interested in global partnerships and building relationships with people from all over the world. And there's a lot of resources. And if you have any challenges accessing them, let me know. But we do webinars, and we cover a lot of these like non-melanoma skin cancers in much more details. We have virtual tumor boards where we'll talk through cases. We actually even hosted shared tumor boards with people from all over the world. So please use these as a resource, and then feel free to email me personally with any questions at any point. I hope that was helpful. This is for my research stuff, but I'm happy to take questions. I see a hand.
Thank you very much, Dr. Boland, for this wonderful lecture. And we have one question from Dr. Ismailov, please.
Hello, thank you for your lecture. And I have a question about melanoma, specifically about vaccines. So you're saying that it is possible now to take a biopsy out of melanoma, then send it to a company, and they modify it to make a vaccine. So my question is, will it be possible to make a vaccine that would prevent melanoma, like the one that you could inject to prevent the disease before it even started?
Oh, that's a cool question. Yeah, no, great question. So yeah, just to explain in more detail, the personalized vaccines right now are personalized. So they are looking at mutations or proteins, or actually it's mRNA, but things that are unique to an individual. So that's why they're like patient specific, and they take a little while. To your point, could we have off the shelf ones? In advanced disease, maybe there are enough shared antigens across melanoma for prevention, which I love your idea. I think it's awesome. The only problem is that some of the benign nevi, so like you move from a nevus to kind of atypia to melanoma in situ to melanoma, some of those molecular changes occur pretty early. So like even BRAF, which is a mutation in 50% of melanomas, occurs in benign lesions. So I think it's something worth pursuing for sure, but I think identifying what are the true markers that differentiate something that's going to be benign and sit around from something that's going to be aggressive. And at least right now, we don't have those markers, but it's not to say that that's not feasible. In fact, we're putting in a grant to look at to create an atlas of precancers for just that purpose, which is what are the features in early disease that correlate with bad stuff. Most people are going to do fine, and we could maybe just leave them be or do simple excisions, but can we identify the really high risk features early? And those would be the things to vaccinate against, but we don't have that data right now.
Thank you. Another question from Dr. Boyarsky, please.
Thank you for the great lecture. My question is about what treatment should we consider for melanoma of unknown primary? As for the same stage, third or fourth of cutaneous melanoma, and what treatment should we consider for primary lung or gastric or intestinal melanoma?
Yeah, great question. So for the melanoma of unknown primary, and I didn't include the slides on rare melanomas, but that's actually an interest of mine. So from the TCGA, which is the Cancer Genome Atlas Project, was the sort of landscape biology paper, and I was involved in that paper as a resident, or as a fellow rather. We looked at the unknown primaries because I was always worried, are they more similar to cutaneous or are they more similar? So biologically, they look like cutaneous. And in our studies, we just include the melanomas of unknown primary as they have a UV signature. They look like sun-related melanomas. So, and it looks like stage by stage, they behave similar to cutaneous. So I would treat them as a cutaneous melanoma of equal stage. And that's how I counsel my patients. For mucosal melanomas, I didn't hear exactly which site you said, gastric or whatever, but we've been interested in all these rare melanomas, the sort of inside, oropharyngeal, vulvovaginal, penile, GI. They are biologically different. In fact, we have some funding right now to study them because nobody understands the biology, how similar or different they are. They certainly aren't UV or sun driven. They're immunologically not as responsive to therapies. So actually in China, they don't even bother using immunotherapy for mucosal melanomas because they don't work very well. They still are using chemo and other therapies. And it's reasonable because in their hands and in their data, it's not working that well. We have found that there probably are some, differences immunologically, in those tumors. And so we're trying to figure out, could we augment immunotherapies, which we like to use because they ultimately can give you longer term control. But yeah, they're completely biologically different. And same with acral hands and feet melanomas. They're, I would say in the family, we kind of think cutaneous, acral, mucosal, ocular, or uveal in terms of like similarities to differences or good to bad in terms of response rates, but they are all very biologically distinct.
Thank you very much. Next question from Dr. Nozdrin.
Thanks for the great lecture. Maybe I misunderstand one slide, or maybe I did not get it right. So there is a variant for their surgical treatment of a 4-stage of melanoma after or before the immunotherapy with good response or with solid mets. Like when we can consider a surgical resection of extended disease with melanoma.
So just to make sure that I'm understanding, for stage 4 disease, like, are we talking about the
Yeah.
Okay. Yeah. So for stage 4 disease, I didn't make it very clear. It's really, we don't have a good algorithm for who should get surgery in stage 4 disease. In fact, Memorial Sloan Kettering and other places have tried to publish series. So we don't know who should get surgery, but I would say that we are operating on patients with stage 4 disease. And I think every meeting I go to, surgeons from all over, we're doing it. And we're doing it based upon our best clinical decision-making, which is often long time of latency, so that they haven't progressed rapidly. They only have 1 or 2 sites of disease, and it's been a couple months, and we're feeling pretty confident they're not going to metastasize elsewhere. So definitely the kinetics of growth, how quickly they grow. People haven't really looked at site-specific differences, meaning is it more favorable to resect a lung met versus whatever? There's no data to support that. But I do think that we've become much more open to, even since I began in practice, this oligometastatic stage 4 resection in patients, not as the first treatment, but if they're doing well otherwise on their treatments, then it's something to consider. And our data that I showed suggested there is a subset of patients who get benefit, but it doesn't tell you who those patients are, unfortunately. And that's up to clinical decision-making. But my guess would be, patients who had delayed recurrences, so they got benefit for a while, 1 or 2 sites of disease, or patients who had a good result and have 1 or 2 sites of persistent disease. That's who we generally operate on.
But may this surgery worsen the prognosis of this patient? Because we know from the abdominal oncology, some operation with the 4-stage disease may worsen the prognosis for the patient with stage 4 disease.
I think there's some suggestion that there's an immunomodulatory. I've heard that from some of the GI cancers when I was training, that there's this concern that surgery may cause like an functionally immunosuppressed state that's not beneficial. I would say in melanoma, most of these patients we're operating on have seen immunotherapy. So they're kind of at a benefit, right? They're on the better part of the curve in terms of their immune system. So any functional suppression of surgery is probably minor. It's not going to contribute so greatly as it might in other diseases where they're sort of on this side of the curve in their immune system and tumor. But I think we haven't seen any of the negative effects of the actual surgery itself. And we've seen patients who've, had maybe a metastasis for years. We finally resect it and there's still viable tumor in there. It's crazy, but they've only had that 1 little site of disease.
Thank you very much. Another question from Dr. Chervonochenko, please.
Thank you very much for the lecture. My question is, what would you recommend for a patient who comes in to an oncology clinic with a history of skin lesion, which was excised somewhere else, not in the oncology setting, for example, in general surgery department or in dermatology clinic, and then the patient gets a histology of melanoma. So what would you, if the patient doesn't have any obvious evident clinical enlarged lymph nodes, what would your recommendation on the management? Only local excision of the scar with adequate margins, or maybe any other interventions?
It sort of depends on the extent of excision. So if we're talking about a primary melanoma that somebody excised, you know, like a couple centimeters, if it's a high risk, so usually intermediate thickness greater than 2 millimeters and or ulcerated, we would re-excise to the proper margins and do a sentinel node biopsy, unless they were old, sick, medically morbid. You know, I take very seriously the fact that the sentinel node is prognostic. So if the patient's not going to live long enough to benefit from that information, right? Let's say they're 94, I'm not going to do a prognostic procedure, but in a young person who's healthy, I would generally do a sentinel node. You know, if it was like a massive 4-inch, or, you know, they'd done some massive thing where I thought the mapping would be really unreliable, I probably wouldn't. And sometimes here I would even monitor those nodal basins with an ultrasound to make myself feel better, to sort of do something.
But you would always re-excise the site of excision.
Yes, like a biopsy is not an oncologic excision. So I see patients all the time where, like, it said the margins were negative on my biopsy, but I'm like, well, that's not an oncologic excision. And you will have increased local recurrence if you don't take more. Yeah.
Thank you.
Thank you. We have another question from Dr. Lisetska, please.
Good evening. Thank you for a great lecture. And my question is, what the strategy to treat and observe the patients with 3-stage of melanoma and HIV or AIDS?
Oh, I think we would treat them the same surgically. And it depends, I guess, on, you know, are they in good control? They have HIV, or do they have flagrant AIDS and are sort of in a functionally immunosuppressed state? I think that would probably factor into the decision-making. I think the surgery would be the same regardless. And then the question becomes, you know, in stage 3, if we're using it as an adjuvant, I think we'd have a long conversation with the infectious disease docs and our medical oncologists on, like, what would happen in that setting. I feel like we've done this, you know, talked through these kind of cases, but I can't recall like what the final recommendations are. The patients we really struggle with are patients who are organ transplant patients, right? Who are immunosuppressed and then get melanoma. Those are patients where, you know, surgery's easy, we'll do that. And then, you know, if they have widespread metastatic disease, then we start thinking, because if we turn on the immune system to fight their cancer, it's going to reject their organ. And so those become very complicated. But the HIV AIDS, I feel like it's not a complete no-go, but it would definitely depend upon what their disease burden was, you know, like what their viral loads are and things like that.
Thank you very much. So I don't see any raised hands. Thank you, Dr. Boland, for this amazing lecture, very helpful information for our Ukrainian colleagues. And thank you also for joining HealUA application. And I highly encourage our today's participants to use and continue use HealUA application. If you have any questions, please ask any question regarding melanoma. We have a large Ukrainian community of physicians there, and our lecturers from Principles of Surgery also joining consistently. So we will see you in HealUA, and thank you again, Dr. Boland, for this lecture.
Yes, of course. And if I can help in any way, both personally or through the SSO, if you guys have questions or want to access any of that content, just let me know. I put my email in there.
Thank you.